Dear colleagues and participants of the African Clubfoot Conference 2022, I would like to present you the MDO Training Kit suitcase, where you can find a lot of good and excellent prepared tools for a good teaching and a good understanding of the clubfoot deformity and how to perform a good standard treatment to correct the severe foot deformity. I would like to introduce myself. My name is Anja Helmers. I'm working at the EWK Hospital in Berlin, Germany, and I'm head of the pediatric orthopedic department since 2005. Start with the clubfoot treatment as a resident in November 1999 and with the Ponseti method in January 2005. Since then, I'm extremely enthusiastic in treating club feet with that method and be part of workshops in Germany, India, Mali, South Sudan, Togo, and with multiple stays abroad. Which are the milestones in treatment of clubfoot? We have that excellent paper from Dr. Ponseti himself, 1963, in which he is introducing us into his special and completely different method. We have his green book published 1996, The Congenital Clubfoot and His Treatment. And since then, the method was spreaded, especially in the first time, 1996, by John Herzenberg, as well by parents, especially over the internet. So the internet, I think, was in this time extremely helpful to spread it over the whole world. We have that excellent sustainable clubfoot care project initiated by Shafiq Pirani 2006 in Uganda. And we can say since then we have 25 years now of global Ponseti clubfoot treatment. And in the main countries and in the main treating centers, we will have over 90% of primary correction, but we also have 10 to 40% of relapses. And we have to analyze that, how we have sometimes 10% and sometimes 40%. It depends on many reasons, like the primary correction, if it's good enough, if it's done at anatomy, if the brace adherence is adequate. So there are many reasons for a relapse, especially also if the clubfoot is syndromic, neurological, or if there are many other reasons for a relapse. The clubfoot relapse also can be treated in a special way, also developed by Dr. Ponseti with the tibialis anterior tendon transfer. Now we can say, how can we get the first primary correction in over 90%? How can we get that? That's extremely important because the clubfoot treatment depends on a good standard, a good knowledge and understanding of the deformity, and a good technique to apply a plaster as a second skin on the baby. So we need a good education of every resident who wants to learn the method, and we need good education tools for that. And here is the point where MDO is coming in to improve our knowledge with that excellent tool suitcase I would like to present to you. So I would like to take you to the wonderful clubfoot journey. The main step to start with the treatment is a good diagnosis. So the equinus deformity is the main pathoanatomy deformity, which is telling us that we will have a clubfoot. After the good diagnosis, we start with the treatment phase. We need for a primary correction 6 to 8 casts. And first, we manipulate the foot in a good correction position and apply a tight cast on the baby foot to correct the deformity. After the casting phase, if we get 70 degrees of abduction, we have to perform the tenotomy. The tenotomy is extremely important to get a better range of motion in the upper ankle joint and to beware the child against a relapse. After applying the last cast for 3 weeks after the tenotomy, we're starting with the bracing phase. The brace has to be applied in the first 3 months, 23 hours per day. And after the 3 months, we can, the brace has to be on the child over nighttime, nap time, for 12 to 14 hours per day until the 4th birthday. The education and improvement depends on a good education. So we need workshops in a good quality, and for a good quality, we also need a good training model. Here's MDO coming in with the MDO training kit, and every tool is in a suitcase. And I would like to introduce that suitcase to you. And on level 1, we will have the measuring tape, the tenotomy model, the tenotomy practice model, also a lot of synthetic tendons for every participant to create his own tenotomy. We have boots and bars for analyzing. And we also have a vertical talus model for the reverse Ponseti method. And we have that mainly and most important model, the adult clubfoot model. On level 2, we will have 3 rubber leg models, which can put with pins on a plate for more stabilization on a workshop table. These foot models are in different positions of the foot so that every participant can apply a cast in the first position, second, and third position also, because they are very flexible in the 4th and 5th position. We also have examples of casts so that the participant can understand how to put a tiny and not a tiny, but a tight cast on that baby foot that the foot can't slip out of the cast. If that happened, we also have a complex clubfoot model or a typical one. And Dr. Ponseti created a special treatment for that as well and published that in a paper in 2006, the treatment of a complex clubfoot. I think this model is also extremely important for a beginner to understand how to handle this severe deformity, which can happen in every clubfoot career. So I think everybody created such a deformity in his first times of studying treating a clubfoot with the Ponseti method. So don't worry about that. We also have level 3 with the plates and pins. So now I would like to take you to that clubfoot journey again. And we start with point 1, get a good diagnosis. So we have that perfect created clubfoot deformity model where you can analyze the whole pathoanatomy of a clubfoot. We have that hindfoot varus. We have that equinus position of the heel, of the calcaneus. We have the forefoot adduction. We have the forefoot supination. We have that hyperpronated first metatarsal, which is creating the cavus deformity of the clubfoot. We also can analyze with that model how to treat that clubfoot in the way Dr. Ponseti is recommending to us, developing by his method. We have pointed out the head of the talus as a right pressure area to correct the contact pressure, to correct the deformity where we have to put our thumb on. We have that no area. The no area is the calcaneo-cuboid joint. And this joint was the area many doctors before, like Imhäuser, Kite, and many other doctors, start to correct the clubfoot. But in this area, it is not possible to get a good correction. I will show it to you in the correcting movement. How is to do the movement? We have to lift up the first metatarsal, and the contact pressure point has to be on the head of the talus as the center of the deformity. This is the cora of a clubfoot deformity, the head of the talus. And when we lift up the first metatarsal, touching anything else, only the head of the talus on the other side of the foot, we can correct completely the cavus deformity. And what you can see also or analyze with that model is the correction of the hindfoot. So what you can see is if we go into abduction, the hindfoot varus is going into the physiological valgus. And we also get a stretching of the dorsal part of the capsule of the lower and upper ankle joint. And when we're creating that anatomy, we will have a good range of motion and dorsiflexion if the capsule is well stretched and the heel is going more and more in the valgus position. This model is extremely important to understand the whole deformity and how to do the correction. Now we're starting with the casting phase. If we go have the right and correct correction. And for this, we have 3 different rubber leg models in the suitcase in different positions. So here we will have the clubfoot deformity like it's coming to us if the child is a newborn. We will have a little bit more correction in this rubber leg model, as you can see right here. So here you can start in the first model, you can start with the first position of the casting. In number 2, you can start with more and more abduction and learn that and put a cast on. And with the third one, after the tenotomy, you will get more dorsiflexion and you have that model to put a cast on after the tenotomy. If we're getting 70 degrees of abduction, we can do and perform the tenotomy. This is sometimes for some doctors a little bit scary because they can't see where they have to do the cut because it's percutaneously. So they have to know exactly which is what is under the skin and how is the relationship from the tendon to the neurovascular bundle. So we have that excellent model where we can see where the tendon is and how is the relationship to the neurovascular bundle. And for many participants, it's extremely helpful to have a model to see how the relationship is and where they have to put the knife on. And also is it extremely important to see where the cut has to be done. So if we are aponeurotic, so a little bit too far proximately, the tendon is too wide and it's difficult to cut them completely. It's the same thing we have close to the calcaneal bone. It's also difficult to cut the tendon here. So you have to go, we can say like a centimeter above the calcaneal bone to perform the tenotomy on the right point. We also have that excellent tenotomy practice model where you can analyze how the tendon relationship is to the artery, and we have artificial skin we can put above, and every participant in the workshop can create and perform his own tenotomy and can see if he is injuring the anatomical structures behind the tendon. Extremely important. I think every participant feel more sure if you can create and perform a tenotomy with a model and not in the first step with a real baby. We also have these cast models where every participant can analyze how the cast has to be performed. And I also would like to introduce you, in the casting phase, a foot can slip out of the cast and a complex clubfoot can be developed. And this is sometimes the main error is that the cast is not tight enough. And for me, it's important to tell to every beginner that it is not a catastrophe and it can be handled and it can be performed to a normal foot as well. But you have to change the treatment, the way of treatment. And this model will help you to learn that. So we have to put our pressure points in a different way. The foot is sometimes extremely swollen, sometimes also painful. If it's extremely painful, then it's better to wait 4 to 6 weeks and let the foot coming back in his deformity, in his congenital deformity. But if it's not so painful, you can start a different treatment to the regular one. We have to put the head of the talus back into the ankle joint like we do in a regular way. Then we have to put our index fingers on the head of the talus and on the lateral part of the foot, on the medial part of the foot, and our thumbs under the foot and have to lift it up. And then you can put a cast on. So that's extremely helpful to understand that severe deformity and also to lose, or not to lose, but it's also helpful to learn how to handle this severe deformity. Then we come to the bracing phase and need well-fitted boots and AFOs. And we also have that example of the bar in between to analyze that and to understand how it has to put on a child's foot. Here are 2 examples of my workshop in Togolome. These participants were very well trained in casting and in manipulating, but not in performing the tenotomy. So it was extremely helpful to have that tool in that workshop, and every participant can perform his own tenotomy with that artificial skin model. We also had the opportunity to learn casting on a complex clubfoot. So if that happened, the participants knows then how to handle this severe deformity. So I think the tenotomy model and the complex model are extremely important to learn the tenotomy performing, and also to learn how to handle a severe clubfoot deformity when it is developing by slipping out of the cast. So now I have to say thank you for your attention. I wish you an excellent conference, good discussions with colleagues, and a lot of knowledge improvement. Thank you very much.